Hi, thanks for coming. I'm Joe Bigley. I'm the founder and CEO of LiveTeleHealth. We provide a video communication module as a element of a telehealth solution, and it'll become more clear why I qualify it that way. By way of background, I did about 10 years of clinical work in hospital settings, clinics, that sort of thing. Then took a kind of right turn in my career and went into advertising and marketing. In 1996, I got into online marketing, so I was one of those early adopters shifting over. I moved from online marketing into marketing technologies, and so by way of explanation, it will become clearer that my particular approach to this marketplace has resulted in a particular solution that lends itself to certain use cases that are better than others. So we've been waiting for this year for about 90 years for telehealth to really hit its stride. Obviously, it's a very big market. It's growing rapidly. There's a series of economic, social, just community types of forces moving it that way. Just yesterday, the ATA came out with a finding reported in Med City News that now more than 50% of hospitals are providing patient treatment of some sort via telemedicine. That's a tremendous stat. For someone who's been in this field for about 5 years, it's been coming. I've been going to ATA conventions and meetings. More than 50% of hospitals now having some sort of treatment form is really pretty outstanding. Howard has already gone into this. I should have read his presentation a little better before, but essentially what started as telemedicine was, physician to physician kind of consults, whether it was via the phone or video or a variety of methods. It's really been expanded to telehealth, telecare, and that now includes a lot of other types of services beyond just the physician. So a lot of wellness, healthcare, those types of things now fall under that umbrella, and including clinical and non-clinical kind of applications. What I'd like to do is walk you through what my experience has been in, peddling my wares. Each engagement we find is absolutely unique, that the particular organization or the use case has different requirements. And that's why I said at the outset, we provide the video communication module. There's a lot of other pieces of technology that typically go into a solution. And so just the integration of the technologies themselves is typically a fair portion of the project. So I got very lucky. As I said, I had come at this marketplace from a online marketing customer service approach. And if you're at all familiar with the text chat services that are out there, if you go to a website, you're shopping, you can't find what you like, you can click on the customer service button and a little box will pop up and you text chat with customer service. They help you get where you want. In 2005, I thought, wow, if text chat is great, imagine if you could see the person and speak to them. Wouldn't that help online sales? So I received a kind of mysterious phone call about 3.5 years ago from a gentleman at the University of Illinois Chicago's medical school who was running their telehealth lab and vetting virtually all of the video conferencing solutions that are on the market. Everything from a $500,000 fixed point telepresence system from Cisco down to Skype, FaceTime. And so his interest in my technology was a little odd, and I didn't quite grasp the attraction at the time. What he saw as really unique was not that I came at this from a video conferencing approach, but as a customer service application. And so a lot of the functionality that we had, and I considered de rigueur, he was astounded by it, because having looked at all the video conferencing solutions out there, ours was kind of unique. So it is currently about 18 months installed at Intermountain Healthcare. It's the video communication module for their employee benefits program. Here, Intermountain, obviously, if you're familiar with them at all, they're leaders, they're early adopters. They have their own innovation labs, they have their own staff. They had a whole plan, which they kind of dragged me into, where I was the video communication portion. They have their own EMR, they have other devices that they can attach, otoscopes and that sort of thing that you've seen. And so they kind of they were my teacher, my mentor, and employing our technology, which I'll show you in the end. Other applications, as we've gone out into the marketplace, it seems each encounter that we have comes with its own set of integration issues, and the use cases just go on and on. So, you know, providing patient communication through a patient portal is kind of a layup. Another interesting case we're involved in is with a series of urgent care clinics, 5 urgent care clinics in Upper New York State, where they'll have one clinic that's overloaded at some time and staff that's sitting around idle in another one. And so by having a telehealth solution in place, they can load balance across clinics and see more patients faster, essentially. Earlier, someone mentioned remote monitoring. So you may have monitors in 1,000 patient homes. When the alert goes off in the call center, the decision is, do we transport that patient, or is it something that can be handled at their home? Oh, you forgot to take your med this morning. And the ability to be able to see that person and assess them right at the time can you know, include a lot of cost savings, hassle, and the like. So more recently, the application has kind of come back here to almost a customer service application again. We have a clinical trial recruitment campaign that's due to launch at the end of this month. This particular trial has been recruiting for about 18 months. They're at about 50% of their goal. And because customer service of all types leads to greater conversions, whether it's sales or signups or you name it, their interest is in providing immediate assistance to someone. They're spending thousands and thousands of dollars to drive traffic to this page to see if someone qualifies. Have you been diagnosed? Have you been using a particular type of treatment? It's a 2-question questionnaire. One of the answers is, I'm not sure. If you're not sure, we want to be able to provide assistance rather than let you go. You know, each subject in the study in and of themselves are worth tens of thousands of dollars to that pharmaceutical company. If we get somebody on the site, we want to be sure we can engage them and recruit them if that's appropriate. So I just lost my screen. Let's see if I can wake it up. Oh. Grant. Help. I know this is going to be something simple.
Yep.
Touch the screen.
Just touch it. Give it a minute. There you go.
There you go. You wouldn't know I have a technology company, would you? Okay, so from the beginning, we don't want to really go from the beginning. So the advantages to telehealth, I think by this point are pretty obvious to most. Expanding healthcare to greater geographies, to greater populations. In the case of Intermountain, reduced worker absenteeism, that sort of thing. Rather than taking 4 hours to spend your 6-minute visit with the physician, just go on your PC and stay at work, get your prescription refilled, and off you go. So there's really two key factors, which was the learning for me, which started initially with the University of Illinois Chicago's medical school when they were vetting all of the various video conferencing technologies. There's two takeaways, and why in an RFP with Intermountain, where Cisco, Microsoft, Polycom were all in that same RFP process, LiveTeleHealth, which is a 7-man operation out of off a kitchen table in New Jersey, won that RFP. And it's really because of two things. Ease of use. It's got to be simple. I think Howard mentioned, or Les was it, that if it's difficult or you need instruction for how to use something, it's just not going to work. People aren't going to adopt it. And the second thing is, and this was the key with University of Illinois, was that it has to work into current workflows. If it doesn't suit the way you go to work and the way you conduct your job each day, then it's not going to be adopted. And so what I'd like to do is just go into a short demo of ours and explain some of those differences and why ours is the appropriate solution for some scenarios, obviously not for others, but let's see if I can navigate this. And so what you see on the screen is a demo Howard and I conducted recently at Mass General. And what I'm about to show you is in the industry what's called presence. You see Dr. Abrera, when he first appeared, his little light was red, showing that the doctor's not available. Now that I'm logging in, his light turns green, and the first thing we do is engage the video, and we get Grant to help us out. This way we can see both sides of the conversation. So on the your left is the clinician's interface. The right-hand side, a page where a patient can come. In this case, it's just a listing of physicians. You'd be able to scroll through. And with one click, a patient can launch into a video consult with a physician. If we can connect. There we go. And so you're hearing the call just like a phone call. And this is one of the keys. First of all, we've been able to route this call. So you can see that when the call came in, and I'm juggling mice here in two different hands, it was routed into our reception room. And we could have any number of clinicians or staff in that room ready to take the call. You see the status of Dr. Abrera is green. And so with one click, he takes that call into the queue, and with the second click, he's speaking to the patient. This patient can turn on their microphone. I'm not going to, their camera. I'm not going to be able to show that right now. The PC does not have a camera. In any event, with a single click, the physician is now speaking with the patient. It requires no download. It's simple. It's really simple for the patient experience. For the physician's experience, there's quite a bit of functionality that we've built into the back end that allows that workflow to happen. If you have a telepresence system which is in a separate room and it requires that the doc take a part out of his day and schedule to be in that room, it's intrusive to his typical workflow. He's not going to do it. um, if it requires that he call the IT department to come set it up each time he uses it. So quite simply, he can go, he can log in to the interface, and the workflow is really here, and the ability to route calls to different departments for a clinician to engage a patient, place that patient on hold, perhaps consult with another clinician and say, hey, I have Mrs. Smith on a call right now. Are you available to see her, and be able to transfer that call just like phone calls. And so a bit of this functionality I can't show you without multiple logins, but what it allows is the treatment of video calls like telephone calls. Every clinician takes phone calls. They've been taking phone calls forever. If now the phone call just arrives on your PC, and with a click you can accept that call, with another click you can transfer that call or place that call on hold. That's the kind of workflow, which sounds quite simplistic, which the vast majority of video conferencing solutions in the marketplace don't accommodate. So at this point, I'll questions or yes?
Who pays for that? So you just used your physician's time. He rendered a diagnosis perhaps, or there's a disposition to his conversation with you as to follow up. How is his time? Who actually pays for that consult?
It's a great question, and it's been the stumbling block for the past 30 years to telemedicine, and it's never going to go anywhere until we figure out the payment. A little background story. The mysterious doctor from the University of Illinois, Chicago's medical school, when he called me, was also the director of telehealth for the state of Illinois. Until there's reimbursement, it's not going to happen. Well, Illinois 4 years ago mandated Medicare and Medicaid reimbursement for telehealth. In the first 24 months that it was in place, he, as the director of telehealth, received exactly 16 requests for reimbursement. So the contention was, at least his belief, and why I eventually got dragged into his his vetting process, and was that it's the technology. If it requires interruptions to the workflow, if it's hard for the patient, then people just aren't going to use it. And I think you can relate that to virtually any technology. If it's not easy to understand, you're not going to use it unless you're forced to. If you're forced to use a remote control on your television that needs a master's degree, you'll do it and you'll study, but you would rather not. And so it was really ease of use and workflow that were the determinants in their selecting this application. Does that answer your question?
Another way. Dr. Agarwal, you want to share your thoughts on how this is going to get paid for?
See, in our model, we have a person opens up an account and see how we calculate it was. Basically, take an example, doctor's fees, $65. When he's in his office, the overheads are about 25%, right? Whereas when you're using telemedicine, and say suppose we gave what you call a fee, say cut it down to about $40, $45, right? Then copay these days is about $30.
financing a $150 bill just to get their kids the vaccination or inoculation. So that copay office visit is not the model that I've seen. The other issue is you have liability. So when I go to my doctor's office and he writes something and records it, that's the only physical evidence of our meeting. Since liability insurance is, or malpractice insurance, has really been the sticking point in so much of the cost of healthcare that for some reason this administration did not reform when it had the opportunity to. You have basically visual record of doctor error. I don't know many physicians who are going to be interested in participating in such an opportunity, even though it may actually improve patient care and communication, just for that reason.
It's a great point that you make, and we've built video recording and archiving into our application simply because the question comes up so much. Not a single practitioner has actually used it. We have tracking, all electronic tracking for, when did the call begin, how long did it last, blah, 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 all, the typical. But my question for any physician is, how long have you been taking phone calls in your practice? And how many of those have you recorded? People don't record phone calls simply because you can on the internet. Doesn't mean you're required. There is no regulation requiring it. And in fact, it could potentially become a liability. And so, Doc, do you answer the phone? Do you talk to your patients? Do you document it afterwards? Yes. Okay, do that here. I think your response to the copay model is an interesting one, and certainly there's a large portion of the population where those types of concerns arise. I brought up the Intermountain one because, again, this is an employee benefit program. Depending upon the insurance coverage that they have, it states when you click here, it's going to cost you either $10 or $50, depending upon the policy that you have. But I'm finding that consumers in general, or perhaps the higher end of consumers, are very willing to pay the copay simply for a convenience factor. And I use that case if you have to take the afternoon off to see the physician for 3 to 6 minutes. Is it worth doing it this way?
One more question, then we'll go to our other presentation and we'll continue.
So, Joe, just a quick question. Do you think the most potential it would be in the business model of employee assistant programs or in the larger consumer market, physician to consumer?
I know that Intermountain has initiated this first as a pilot for 6 months with a subset of their employees. They then rolled it out to the complete 30,000. The intent is, now that they've got a year and a half of experience with it, there's a lot of human processes, aside from technology, that have to be in place. And so the plan is to, yes, start extending it to their outside patient population through Park City General, I believe, is where they're going to launch it.